Good morning, all, both those here in the audience and the number of you online, and apologies for those online who've been waiting patiently while we've been dragging people away from the pastries and coffee to come in. It's a great pleasure today to introduce Professor Bruce Biccard. Bruce, some of you may have met before because he was in Oxford in 2005 for a year as a visiting consultant, having been working in Cape Town, and he came as a guest of Pierre Foix, and in fact did quite a lot of vascular surgery at the time. And we just worked out earlier today that we'd been appointed at the same time, me in Oxford and Bruce in Cape Town, but we did work together in our 5th year as consultants at the John Radcliffe. So Bruce went back to South Africa and has had this huge influence in global anesthesia and surgery by association in looking at perioperative medicine and outcomes. He's a big proponent of international collaborative research. He's director of the African Perioperative Research Group, and very highly rated globally on work not just during COVID, but setting up the African Surgical Outcome Study in pediatric patients, and is also co-lead of the NIHR Global Health Group on perioperative and critical care. So it's really wonderful that Bruce has been appointed to the chair of the Nuffield Department of Anaesthesia. Of course, he comes in a great line, walking with giants like Pierre Foix and also our current Vice Chancellor, who had his chair before him. He gave his inaugural lecture to the university on Tuesday, and we're very lucky in NDS to have him come and speak to us so early on in his time at Oxford. Bruce, we're really looking forward to what you have to say.
Morning, everyone. Thank you for this opportunity. It's a nice way to meet the Department of Surgery. I know a lot of you haven't met me before, and for that I apologize. But it's nice. Yeah, it's nice to be here. So what I thought I'll do today, well, firstly, I don't have any conflicts of interest. You'll see quite a lot of our research that we've done, but it's all been investigator-initiated and led. I think I'm just going to give you a short story about my sort of research life so you can sort of understand where I come from, and then a bit about what surgery looks like in Africa, and then probably what I consider the 3 pillars that we need to address if we want to make surgery safer. So I'm going to show you work from the African Perioperative Research Group. This is a group which started pretty much on blind trust. No one knew each other, and we blindly contacted anesthetists and surgeons across Africa and built a group, and that ended up in the surgical outcome study, and it's got stronger, and now there are probably about 43 countries, over 1,000 hospitals, and nearly 2,000. These are clinician investigators, so full-time clinicians who do work on surgical outcomes. These are the main outputs from that group. So we've looked at outcomes in adults and peds and critical care. We've done a large randomized control trial trying to improve failure to rescue. And it's the amount of patients or participants that have been recruited. The reason I put that down is to understand that these are essentially unfunded clinicians who've done this work. I mean, it's pretty phenomenal. So I'm fortunate enough to stand here and talk about it, but really It's about these clinician investigators across Africa who've done this work. I think this is my story, my sort of research story. So my research actually did start here in 2005 with PFY. And I got involved in, at the time, I was really interested in perioperative medicine and cardiovascular outcomes. And then I had worked also with PJ Devereux at McMaster. But in Africa, it's more than cardiovascular outcomes. It's all the surgical outcomes are poor. And I think what I was seeing was that there's no money for research, that we got uncoordinated activities, and we were wasting resources. And I think really what struck home was this series in the Lancet in 2015, which is basically on how do you not waste the limited resources you got for research. And so at that time, a group of us, what we did is we got all the people in South Africa that we thought were important researchers in the perioperative space, got them together, and we basically started the South African Perioperative Research Group. And what we needed was a project, and to build this sort of coalition to show you can do stuff. And just before that, the European Surgical Outcome Study had been published. I know there was a lot of controversy with some of the outcomes from some of the countries, but the methodology was super pragmatic in that it was deliverable with limited resources. And Rupert Pearce, who was the leader of this, he shared the methodology with us, and he shared the resources for data capture and basically the infrastructure. And what we did is we ran it across South Africa. So that was a South African surgical outcome study. And that sort of galvanized the group. And then we thought, well, actually, what we really need to do is we need to do it across Africa. And then we sort of cold called Africa. And we went on to do the African surgical outcome study. So that group set up priorities for research in South Africa. And the reason I show you this, you'll see later why this is important. So we sat down, and just like the James Lint Alliance, we worked out the top 10 priorities for the South African Perioperative Research Group. These were the top 2 at the time. And the group went on to do the African Surgical Outcome Study. And this is what we found. We found that if you have surgery in Africa, you're twice as likely to die than if you have surgery anywhere else in the world. So this was at the time like really quite distressing. And it was, how do you tell the story? And fortunately, the narrative was very simple in that the failure to rescue from complications was twice that of the global average, and hence the mortality was twice the global average. And what happened was that instead of people pointing fingers at what was happening in Africa, really got the sense that actually people cared. And I think that was very empowering for the researchers in Africa, that people really felt, okay, there's a real problem here. How can we make it better? So it was very positively received. So that really galvanized the beginning of the African Perioperative Research Group. And so again, as for Africa, what we did is we looked at, okay, what is going to be the priorities for this group going forward? This is why I show you this. So this is the top 2 priorities for Africa at the time, was training standards and minimum provision of care standards for perioperative care. It's just mind-blowing how different the priorities were between South Africa and Africa. And these are things which are well established. I mean, they go back to the 60s and 70s, and here we are in like 2018, 2020, and people are talking about what should the training standards be and what's the minimum provision of care. And so you could see the gulf in sort of things associated with quality and resources through the priorities that came up. So what happened was, although we had these priorities, we also had this terrible signal that people were twice as likely to die. And the feeling was, I think the clinician investigators were really distressed and felt we have to do something about this. So how do you do that in a clinical trial in Africa when you got no money? And so, we thought, okay, we needed a decent clinical trial. It needs to be robust, but we're going to have to change something because we just got no funds to do this work. And so on top of it, besides not having funds, we also knew we had hardly any clinicians. So the Lancet Commission suggests you need 20 to 40 specialists per 100,000. That's surgeons, anesthetists, and obstetricians. And from the African Surgical Outcome Study, we knew there was less than one. So it was about 20 to 50 times less than the recommended minimum in the Lancet Commission. So that was the challenge we had. And we thought the way we can answer this question is to do this massive randomized controlled trial with an outcome which is objective. And when you've got no money, the only objective outcome you can look at is more in-hospital mortality. So as soon as you do that, the numbers just explode. So if you've got a mortality of 2% in the hospital, and you want to show 25% relative risk reduction, which would be a good signal, you need about 60,000 patients. And so we said, okay, well, we'll just do that. And we'll randomize hospitals across Africa to either increase postoperative surveillance or normal care. And the idea was if we could flag the high-risk patient, and we knew what high-risk patients looked like from the African Surgical Outcome Study, and we say this is a high-risk patient, and if we observe these patients, we will pick up complications early, and we will decrease failure to rescue, and hence save lives. So that was what we thought. We got to about nearly 30,000 patients recruited, and COVID started, and it just became really difficult. Difficult because some countries didn't even have PPE. So now you've got this whole thing about how do you do a trial? How do you put clinicians with patients if they don't have to be with them? So you're putting the patient at risk, you're putting a clinician at risk, and then we just stop the trial. And wow, we failed spectacularly. We made zero difference to in-hospital mortality. So no matter how you looked at it, there was no difference. So we had randomized like 30,000 patients and didn't change a thing, which was quite, quite devastating. But fortunately, through the advice of Rupert Pierce, we had set up a process evaluation on the back of the trial. And that was super important because this was a sort of program theory. It was, we can identify the high-risk patients, we'll increase surveillance, we'll identify the complications, we'll escalate therapy, and we'll decrease mortality. The reality is we got no idea what actually happened. So from the program theory to actually what was delivered, we didn't know if they actually got adequate postoperative surveillance, don't know if the complications were identified early, if the therapy was appropriate. So there was massive learning in this. So you do randomize 30,000 patients and find out you don't know what you did. And I think then for me, what happened was we learned so much about part of mortality, which is associated with the health system and the context in which our surgical patients sit. And so I am heavily based on evidence-based medicine. And so I know we need to generate evidence for what we do, but there was so much that we saw that I thought what I want to do is I just want to put it out there, put out what I believe will make the surgical environment safer, and at least people can try it, and they can it can start a conversation, and people can say, oh, that's rubbish, or actually that's quite a good idea, but I think it would be better this way. So try and get that narrative going, and maybe we can change outcomes while we try and generate the evidence. So, I mean, what does Africa really look like from all the work that the African Perioperative Research Group has done? So I'll just quickly take you through these sort of things, like who gets surgery in Africa, what surgery is provided, where and when does it happen, and when and how do patients die. So this is what we know about surgery in Africa. So who gets surgery? Patients are young and fit. So let's say they're about 40 years old, half of them ASA1. We know now, like from the national audit projects in the UK, for example, that ASA3 patients are more common than ASA1 now. So the complexity and the age of the patients here is extremely different to what's happening in Africa, yet you're twice as likely to die in Africa than here. And it's not risk adjusted for what the patients look like. So yes, that's what the UK looks like. So, I mean, when we say you're twice as likely to die, in reality, if it was risk adjusted, it would be way worse. So who provides surgery and anesthesia? So this is what the surgeons look like. And for every category, they're less qualified anesthetists. And you see in some situations, there are no anesthetists and quite a lot of non-physician anesthetists. So what we also looked at was, you know, what happens when non-physicians are giving sedation to enable surgery, because there's quite a drive saying that, oh, you know, you can just do this ketamine sedation, you can do surgery. And what we found was that in that environment, you're 8 times more likely to die or have a severe complication if you get sedation for surgery by a non-physician. And looking at it, what we actually found was it was the environment which was driving this mortality. Because as soon as you get a non-physician giving sedation for surgery, what actually is happening, it tells you in that environment, there's little physician support and there are little resources for general anesthesia. And so this, the sort of work which has been done in high-income countries to show that the outcomes are the same, in reality doesn't translate on the ground when you're in a low-resource environment, because they do not have the same supporting infrastructure. What type of surgery is provided? A third of all surgeries in adults is cesarean section, and about a quarter is GIT in kids. And what we would consider neglected surgeries, so it's all the subspecialties, cardiothoracic, hepatobiliary, vascular, neurosurgery, they're all less than 5% of the surgeries. There are only about 600 cases per 100,000 when you should have about 5,000. And here in the UK, we have 8,500 per 100,000. So you need 8 times more surgery just to address the surgical pathology burden in Africa than is currently provided. And I told you that cesarean sections are the most common, a third of all surgeries, yet we need 3 times more cesarean sections than are delivered at the moment in Africa. So you need about 19 per 100 live deliveries for safe maternal service. And there's probably in the region of 5 to 8 cesarean sections per 100 live deliveries. Then if you look at cancer, we probably need about 4 times more, and then at 20 times more, those are all the subspecialties. So they're almost totally unrepresented. What does the theatre look like in Africa? So in the pediatric surgical outcome study, we actually asked the surgeons and anaesthetists to tell us if they thought the theatre they're working in is safe. So this is what the surgeon and the anaesthetist have reported. So 1 in 2 people who are providing neonatal surgery say they work in an unsafe theatre, and 1 in 3 who do infants say it's unsafe, and 1 in 5 say the theatre is unsafe for kids less than 6. And if you look at, like the behavior, checklists only use about half the time. And when you look at emergencies, in fact, the use of checklist drops off even more. And I do think there's a role for, is the checklist context sensitive? So I think there's a lot of redundancy in the checklist when you don't have everything that's asked in the checklist. And because of that, and then you put it in an emergency environment, I think people start just to kick against it, because why are you going to ask me a question when the answer is always no? So I think that's something that really needs to be worked on also to make the environment safer. The resources for resuscitation are also limited, down from about, so the most basic things for resuscitation of patients in some environments, only 1 out of 5 hospitals actually have them. And then at the most, about 7 out of 10. So that contributes to the failure to rescue as well. More than half of all surgeries in adults in Africa are emergencies, and nearly half are emergencies in kids. Where are these patients dying? Well, most of them die on the ward postoperatively. There's a fair number who die in theatre in pediatrics. And most of these deaths follow GRT surgery. So how do they die? Well, they get complications, there's inadequate resuscitation, hence there's failure to rescue. And the facility is definitely contributing to this. So if you look at like the leading causes of death, bloodstream infection for adults, so their death is a bit slower. There is definitely time to respond. They get infected, they die like at 5 days or 7 days. Mothers is different. They have a quick death. Most of the deaths are associated with hemorrhage. Then the other independent association is actually with anesthetic complications. So either way, the mothers die very quickly. Kids is a bit less clear. I've got cardiac arrhythmias there, but in reality, I think what you're seeing is the critical incidents. And if the pediatrics from Africa is on your right, and that's compared to Apricot, which is a European critical incident study. So this is unpublished data, but I think the big signal here is you can see the blue, the respiratory complications are about double in Africa. And I think what you're seeing is these hypoxic events, and then they've been perceived or reported as cardiac arrhythmias. But I think what this signal suggests is lots of them are having airway problems. They're becoming hypoxic, and then they have a hypoxic arrest. How they resuscitated on the ward. So when we looked at critical illness in the hospitalized patients across Africa, and you look at the surgical ward, is their resuscitation adequate? Well, only 1 in 10 for patients who are actually critically ill. And most of the systems, about half, are actually getting the essential resuscitation they should be getting. Hemorrhage. So we looked also at, so the WHO have got these guidelines on what you should do for obstetric hemorrhage. The reality is, I think for us in Africa is like, what is actually feasible? So we know what's efficacious, but what's feasible? And then you see, like, we think from working with a group in Africa that of the feasible interventions, 5 of them actually are unavailable. And so that's a big problem as well. And the result of all these things is that failure to rescues are high. So adults, like I said, they die predominantly from infections, so there's time to intervene. But as soon as they have quicker deaths, like the mothers and the kids with airways and that, failure to rescue is super high. So nearly 20 times higher than high-income countries for mothers who die from bleeding out. So coming back to us failing with the clinical trial, what we know is we know what the patients look like who are at risk. We know the type of surgeries which put the patient at risk. But in reality, 50% of mortality is tied up in the context. So in the hospital and in the theatre and the country. And so this is also unpublished data at the moment. So half of your death is where you are, another half of the sort of traditional risk factors. And this is exactly the same as the work that was published by the NIHR Unit for Global Surgery and their Global Surge 3, which looked at cancer surgeries globally. They saw this exact same signal that half of the mortality is actually in the context and not the patient in the surgery. So just to summarize what it looks like in Africa, patients are young and fit. The providers are often in unacceptable scenarios to enable surgery. There's only some surgeries provided and many of the specialities are neglected. And I think what this says is there's a massive invisible surgical pathology mortality in Africa. So what we've shown you is what happens when you have surgery. The reality is there are 7 times more patients who are not being treated and probably dying of their surgical pathologies as a result. As an environment which is definitely unsafe, and this paucity of safety mechanisms which need to be addressed. Most of these patients are dying on the ward, but with the pediatrics, there's probably a significant number who actually die in theatre. We know the complications associated with death. There's inadequate provision of resuscitation, and there's failure to rescue, and hence there's mortality, and that mortality, half of it sits in the institution. And this is not just an African problem. So they've done similar work now in Latin America, and the signal's exactly the same. This is hugely relevant because by 2100, more than 80% of global population is going to be based in Africa and the Indian subcontinent. Half the world's population will be in Africa. And so this is a problem that we need to address. So solutions. So these are the sort of 3 pillars that I put down in my book, which I hope in time we can address them. But I think the first is what we learned from ASOS to the clinical trial in the program theory to make change in a surgical environment. In fact, what you do is you've got to change behavior in the space, in the surgical ward, in the theatre. And I've put together what I've called the inside out model, but basically you got to start at the right at the center, and you've got to work out. And the first thing is people got to believe and have like a value system which is consistent with what you're trying to do. If they do not believe in what you think is going to improve outcome, you've lost already. And then once you've through that, you've got a team who believe in it, then you need knowledge and education to understand the program theory so people can execute it. You need an intervention which is deliverable. So, we thought increasing postoperative surveillance is simple, but in reality, it's like got 4 or 5 components at a minimum, and it increases the complexity of an intervention in the surgical space. You've got to track what's happening, feedback where you're failing on an intervention, and then you need the resources. So what actually happens is, even if you build a nice program theory in a resource-limited environment, you get capped by the resources. So that's the second pillar, I think, so we can build teams and teamwork from within our hospital, but we also need people on the outside who are working on capacitating an environment with resources. So you can have an environment, you can have perfect processes, but if you don't have the resources, it's capped. And then the third thing is, I think, is advocacy. It shouldn't be acceptable that outcomes are so poor. I think communities need to be empowered to know that it's not acceptable that mothers die of hemorrhage after surgery, but there needs to be more community activism, which is through education about what we know about poor outcomes. So where do we go now? So after all that, we know what the patients look like who die, and we also know what type of surgeries they die in. But it's that whole 50% of the context that we don't understand. So we're in the process of setting up a continental audit project. So it's built on the structure of the national audit projects, which are run here, the most recent one being NAP7 on cardiac arrest. We've taken the same structure and we're going to do the same thing in Africa, but it's obviously different because we can't do every case in every hospital. But it'll be a massive project, and we'll be looking at perioperative death. So like a confidential inquiry basically into perioperative death to understand, what were the factors that contributed to this death? Was it resources? Was it training, etc.? So I think we have a good understanding really of what's happening in Africa now, and now the focus is on trying to work out these different pathways for improving outcomes. Thank you.